Hello, my name is Dr. Andrew Steubenrock. I'm a resident at the Oshner Clinic Foundation down in New Orleans, Louisiana. Welcome to the newest blog for Cardiothoracic Division of ACOR. I'll be discussing a few different articles of the recent literature, and thank you for tuning in. Our first article is titled Application of End Descriptors Proposed by the International Association for the Study of Lung Cancer and Clinical Staging. This is a recent article in the Journal of Radiology. Researchers from Korea sought to validate the newly proposed end stages as proposed by the International Association for the Study of Lung Cancer. The end classification for lung cancer staging was originally based on nodal location, while excluding tumor burden as a consideration. And the new proposed end system subdivides the N1 stage and the N2 stage into the N1A, N1B, N2A1, N2A2, and N2B based off of involved nodal locations and if skip metastasis is present. So just to briefly describe what the new proposed end system is, the CN1 stage is subdivided into the CN1A, which involves one N1 nodal station, and CN1B, which involves multiple N1 nodal stations. The CN2 stage divided into 2A1, which is one N2 nodal station without N1 involvement, which is the skip metastasis. N2A2, which is a single N2 nodal station with N1 involvement, and N2B, which is multiple N2 nodal stations. This is a retrospective observational study which drew subjects from a population of patients diagnosed with non-small cell lung cancer from January 2010 to 2015. 2,337 patients were initially discovered to have non-small cell lung cancer. Patients were excluded if there was no staging workup, distant metastasis were present, or previous malignancy with evidence of disease in the past 5 years is a part of their medical record. Ultimately, 1,271 patients were included in the study. Images were reviewed by thoracic trained radiologists and assigned a T and N grade based on the 8th edition of the TNM staging system. 2 clinical end stages were assigned, the first based on imaging alone and the final based on all evidence available, such as PET CTs, endobronchial ultrasound, percutaneous biopsies, etc. The final clinical stage was used for the primary analysis. Nodal metastasis was considered if the short axis of the node measured 1.0 centimeters. Additionally, peripheral N1 lymph node zones 12 through 14 were considered metastatic if a 0.8 to 1.0 centimeter node was located along the lymphatic pathway, or if it had other features such as a round morphology, if it enhanced with contrast, or if it was necrotic. Study outcome was determined as overall survival over a 5-year survival plan. The rates were estimated using the Kaplan-Meier method, and the distribution of patients into the end stages are as follows. The N0 was 940 patients, which is 74% of all the patients. N1 was seen in 86 patients, or 7% of the total. N2 was seen in 162 patients, or 13% of the total, and the N3 stage with 83 patients, or 7% of the total. Overall survival rates in accordance with the current staging system were 77%, 48%, 27%, and 12% for stages N0, N1, N2, and N3 respectively. There were differences in survival between adjacent groups, such as between like N0 and N1, N1 and N2, and all were statistically significant with a p-value of less than 0.001. In the proposed system, we saw survival rates measuring 77%, 54%, 36%, 29%, 34%, 18%, and 12%. And that includes all the 2A1s, the 2A2s, etc. that I discussed previously. We found that differences between the adjacent stages were not significant for survival, except between N0 and N1A with the new proposed system. P-value was 0.002. When the N2 stage was subdivided, rates were 77.3, 48, 32, 18, and 12 for stages N0, N1, N2A, N2B, and N3 respectively. All were statistically significant between the groups, or between the adjacent groups, except for N2B and CN3. And they did see that with the N1 stage, lymph node size greater than 2 centimeters was also shown to be associated with a worse prognosis, and there was no difference seen between lymph node size in the N2 stage. And ultimately, what these results show is that subdividing the N2 stages in regards to clinical staging of N2A and N2B can show significant prognostic effect, but further dividing in the N2A1 and N2A2 is not significant for prognosis. Notable important finding was that N2B prognosis was closely related to N3 disease rather than N2A disease. Overall, limitations for the study include lack of generalizability across an ethnically diverse population, as the study population was an ethnically homogeneous Asian cohort. Additionally, this was a single institution study and a smaller number of subjects per variable end stage. Further evaluation with a more genetically diverse population and higher power could show potentially different results. And another potential confounder in this population is the higher prevalence of tuberculosis, which could potentially affect the PET-CT results used in the final staging. Our next article is titled LongRADS version 1.0 versus LongRADS version 1.1, comparison of categories using nodules from the National Lung Screening Trial. This was an article from a recent edition of the Journal of Radiology. Researchers from the University of Maryland have investigated the classification changes seen from LongRADS 1.0 to 1.1 to determine the frequency of periphyseal and ground glass nodules that were declassified from categories 3 or 4A to the more benign category 2. LongRADS is a useful tool that is used to standardize results from low-dose lung cancer screenings across the United States. Periphyseal nodules threshold increased from 6 millimeters to 10 millimeters from version 1.0 to 1.1, and ground glass nodules from 20 millimeters to 30 millimeters between the two as well. Subjects were obtained from the National Lung Cancer Screening clinical trial, and 2,813 patients were initially included within the cohort, as they had an examination that included a periphyseal nodule that measured greater than 6 millimeters but less than 10 millimeters. Nodules were classified using the DeHoop classification system, which had 3 categories: a typical periphyseal nodule, which is a definite intrapulmonary lymph node; atypical periphyseal nodule, which is a periphyseal nodule was likely and it meets most of the criteria; or a non-periphyseal nodule, which is more of a parenchymal or pleural-based lymph node. For this study, they included typical and atypical periphyseal nodules to meet the criteria for periphyseal nodules. These were assessed by a fourth-year medical student with supervision from a cardiothoracic radiologist after training, and each nodule was organized by its characteristics. Data sheets were reviewed to determine which nodules proved to be malignant for each patient, which required pathologic proof. Benign nodules were considered benign if there's stability over the follow-up period, or if there's pathological proof that the lesion itself or the node itself was benign. Overall, 1,092 solid nodules across all studies were used for analysis that fell within the 6 to 10 millimeter range. 71% were considered category 3, and 30% or 29.3% were considered category 4A. 216 of these nodules were considered PFNs when LongRADS version 1.1 was applied and downgraded to category 2. 11 total solid nodules within the 6 to 10 millimeter range were found to be malignant. However, none of the nodules that were judged to be a periphyseal nodule that were down categorized to category 2 were deemed to be malignant, showing that version 1.1 of LongRADS was found to be statistically significant for better detecting malignancy with solid nodules than version 1.0. As far as ground glass nodules go, 161 were present total, 158 were category 2, and 3 were category 3 using the version 1.0 criteria. 2 of the nodules in category 3 were downgraded to category 2 with the 1.1 criteria. 4 total ground glass nodules across the study were found to be malignant, 2 in each category of 2 and 3 using version 1.0, and 1 of the downgraded nodules using the version 1.1 criteria was found to be malignant. Statistical analysis showed no significant difference was found between the 2 versions for detecting malignant nodules. Overall, they found that LongRADS version 1.1 was found to perform better in detecting malignancy when compared to version 1.0. The p-value was less than 0.01, and the researchers extrapolated their data set to apply it to the entire NLST trial data set to suggest that version 1.1, 3.4% of the studies would be downgraded, reducing the false positive rate seen across the study. Limitations for this study include the fact that it is a subset of the total data set of the National Lung Cancer Screening Trial, and although with the overwhelming number of patients in the trial, an analysis of each patient would be inefficient. technique issues between scans could also lead to problems as different CT scanners can perform studies differently, even with similar base parameters. Our next article is titled Central Tumor Location at Chest CT is an Adverse Prognostic Factor for Disease-Free Survival of Node-Negative Early-Stage Lung Adenocarcinomas. This was a article from Radiology as well. Researchers from Korea sought to investigate the role of the two proposed definitions for central lung cancers in regards to their prognostic value and the prognostic implications of a quantitative definition of central lung cancer. Central lung cancer is associated with mediastinal node metastasis and occult in two disease. However, uniform definition for central lung cancers are lacking. There are two proposals. The first is the inner third of the lung, as defined as concentric lines from the hilum, would constitute a CLC, and the second proposed mechanism is an inner one-third, as defined by the concentric lines from a midline based on axial CT images. So just a slightly different midline point to where they would determine the inner third of the lung. The particular study is a retrospective study examining patients from 2009 and 2015 at the Seoul University Hospital with patients with a pathologic stage of T1A, N0, M0. Exclusion criteria included sublobar resections, no mediastinal lymph node dissection, non-adenocarcinoma histologic type or adenocarcinoma in situ, synchronous or metachronous lung cancers, no survivable data or missing clinical variables in the electronic medical record. The pathologic stage was initially based on the 7th edition of the American Joint Commission on Cancer Staging. However, T-stage was determined using the 8th edition with retrospective measurement of the cancer lesions by the researchers. Primary endpoint was defined as disease-free survival, which is disease defined as date from surgery to the first clinical recurrence and or distant metastasis, as confirmed with imaging. They used both of the above discussed proposals using the concentric lines from the hilum and the midpoint. Then they also developed a quantitative method to reduce the potential subjectivity of the first two proposals. The quantitative method used an intersecting point between the horizontal midline of the thorax and mediastinum as the central point, and then derived the thirds of the lung from there. They used additional two quantitative definitions as well. Definition 4 is a subset of definition 3, and measurements include the inner third of the lung. And definition 5 was similar, but used the inner 2/3 of the lung as central lung cancers. Tumors were assessed for each of the three definitions by thoracic-trained radiologists, and 436 total patients were used for the study. Clinical history and demographics were obtained, included in the multivariate analysis, and inter-observer agreement used the Cohen test. So for definition 1, 34 patients were found to have central lung cancers, and 3-year disease-free survival was 87.4% for central and 93.7% for peripheral tumors. Using definition 2, there's 55 patients, and 3-year disease-free survival was 92.1% for central and 93.4% for peripheral tumors. Definition 4 uses the quantitative inner third of the lung and had a total of 10 patients with no events. Definition 5 had a total of 130 patients, which is the definition that used the inner 2/3 of the lung, with a 3-year disease-free survival of 89%. Multivariate analysis showed that definition 1 and definition 5, the inner 2/3 proposal, central lung cancers had an almost 3-fold higher risk of recurrence or death when compared to the peripheral counterpart. Interaction terms between each definition and other variables were not significant and thus not included in the models. They found that inter-observer agreement for definition 1, which was a subjective evaluation, was considered 0.52, and that as part of the range of agreement values, that was considered moderate agreement. And for definition 5, which used the quantitative measurement, the value is 0.86, which is almost perfect agreement. Overall, this study validates the prognostic value of disease-free survival using both qualitative and quantitative measurements in patients with resected, node-negative early-stage adenocarcinomas. Central lung cancer was also shown to be adversely related to disease-free survival compared to peripheral cancer counterparts. Limitations for this study mostly revolved around the data set. It was a retrospective study from a single institution with a small number of patients and limited events. I feel like a larger multi-center study could validate these initial findings and provide more concrete evidence in showing the results and to help form a universal definition for central lung cancers. Our final article is titled Long-Term Prognostic Value of Coronary, CTA, and Orthotopic Heart Transplant Recipients. This was from the Journal of American Rheumatology. A group of researchers from Pamplona and Madrid sought to investigate the prognostic value of coronary CT angiography in patients that have undergone orthotopic heart transplant. The cardiac allograft vasculopathy is leading cause of graft loss between 1 to 3 years after the transplant is a major factor of long-term survival. Currently, conventional coronary angiography is the accepted standard for CAV, but limited as you cannot see the vessel lumen, and coronary CTA has a potential to be a non-invasive alternative to this traditional method of angiography. This was a retrospective study which included 114 patients that underwent coronary CT angiography for CAV. Subjects were included if there's no clinical evidence of CAV at the time of CCTA. Prior to the CCTA had a negative echo or conventional angiography. Retrospectively, ECG-gated CCTA examinations were acquired, and all studies were performed on Siemens scanners with standardized contrast bolus timing as well as other CT parameters. So patient demographics, risk factors for coronary disease, infections, and immunosuppression data were also collected for analysis. Studies were rated semi-quantitatively as 0% vessel narrowing, 1 to 24%, 25 to 49%, 50 to 69%, 70 to 99%, and 100% stenosis or occlusion. Coronary CTA were classified into two groups in accordance with the presence of non-obstructive CAV defined as a lumen reduction of less than 50% or obstructive disease, which was defined as a lumen reduction of greater than 50%. The primary endpoint of the study was major adverse cardiovascular events, including cardiac death, non-fatal MI, cardiac arrhythmia, unstable angina requiring hospitalization, congestive heart failure, revascularization, either from percutaneous coronary intervention or coronary artery bypass grafting, stroke, or if a retransplant was needed. The time from coronary CTA to MACE was recorded as well. So of their cohort, non-obstructive disease was visualized in 102 patients, roughly 90%, and obstructive disease was detected in 12 patients, which is roughly 10%. 55% of patients had 0% stenosis, 29 presented with the 1 to 24% grade, 18 presented with 25 to 49% grade, 10 presented with 50 to 69%, 1 with the 79%, and 1 with a total occlusion. A total of 21 patients developed a major adverse cardiac event in the follow-up period. Significantly more were found in the obstructive group, 50% of those patients, compared to 14.7% of the patients in the non-obstructive group. And the p-value for that was less than 0.5. They also looked at presence of stenotic coronary segments and was shown that if there's 4 or more, it had a higher risk of MACE, regardless if it was like completely occluded or non-obstructive or whichever category it fit into. Coronary CTA showed a high specificity at 94% and a negative predictive value 85% to predict long-term major adverse cardiac events. The study, of course, has limitations. It's retrospective in a single center with a relatively small data cohort. Further evaluation of the larger population could obviously produce different results, but overall, the study is a good start for risk stratification in heart transplant patients, and the use of coronary CTA can be a great non-invasive alternative to conventional angiography. That's our blog post for this month. Thank you for tuning in, and we will see you again next month.